I'd like to next invite Dr. Irene Gabriel from Dana-Farber. She'll be talking about frontline therapy for newly diagnosed patients.
All right, good morning, everyone. It's really a pleasure to be here in New York, and I want to thank you all again for coming here today in the morning, but also want to really thank MMRF because MMRF truly makes a big difference. Not only getting you the information and changing treatment and how we treat patients and how we bring clinical trials to you, but it also helps us on the other side as physicians, as researchers, moving forward all of those new ideas to bring them to you truly. So again, thank you MMRF for doing that. So what I'll do now, and other than that, of course, all the runs that MMRF does and climb the mountains. So I just climbed Kilimanjaro in the summer, and I'm looking forward to other climbs with MMRF. So please, again, not just join them through some of those meetings, but also through some of the work that they do. What I'll try to take you now through is, now that you are experts in knowing how we diagnose patients with myeloma and you know the differences, you're going to work through trying to understand how we treat patients with multiple myeloma. And I'll take you through one patient that I just saw last week, and then how we actually think as treatment options for a patient with myeloma and how we actually come up with those ideas of which combination to use, when should we do transplant or not, and what are the trials that we have right now. So this is a young patient that I just saw last week, 43-year-old, and he was just carrying his daughter and he felt something pop in his back and he was like, well, it's probably musculoskeletal, it's nothing, my daughter is, getting older and getting heavier, but it didn't get better, and he went to the chiropractor, didn't get better, finally went to an orthopedic doctor and got an MRI, and it showed a big, huge lesion, what we call plasmacytoma, but also multiple other lesions on the CAT scans and the MRIs. And when he went to a hematologist, oncologist, he had a bone marrow biopsy, and basically it showed that he had a packed bone marrow. 95% of his bone marrow was full of those plasma cells, the ones that you just saw that picture of, so really bad cells. And we'll dig through into what are the kinds of plasma cells we have. So when I say cytogenetics and FISH, we will explain that in more details. But his kind of cytogenetics and FISH analysis tells us that he had bad prognostic markers. Some of those chromosomes that tell a myeloma cell keep growing much faster and don't respond well to treatment. So resistance to therapy and just growing very fast. So the patient had already been started on treatment, and you will see again combinations of therapy, putting 3 drugs together. In this case, he even had 4 drugs together, and then is coming now to talk about stem cell transplant. And this is what we usually see in so many of our patients coming in to see us for the first time. So again, how can we diagnose patients? How can we go through the treatment options? And which option is best for a very young patient like this? So the first thing you want to do is, when you're diagnosed with multiple myeloma and you have that shock, the first thing you want to think is, okay, how can I come up with the best care for myself? And I think one important thing to remember is you are an active participant. You are the most important person and advocate for your own health and for your own care. So you have to be part of that decision making, and you have to be also thinking of what are my best options and how to reach them. And I think we talked a little bit about making sure that you also go to a specialist in multiple myeloma. Myeloma is a rare cancer, believe it or not. I know you think that, we see tons of myeloma in the US. It's actually not. It's a very rare cancer compared to lung and breast and all of that. So the local community oncologist is a wonderful doctor, but try to think of going also to a specialist, because this is where we can help you tailor your therapy and then go back to your community oncologist, so that we make sure that you have part of all the new treatments and new options that can be given to you. And because not every single person should get the same treatment. We are not all the same, and we should not, hopefully in the future, receive all the same treatment. So the first thing we think of is age, other factors. Do we have kidney disease or not? Do I have bone disease or not? Is the patient having bad, significant disease like this or not? Then we also look at other factors. Is this high-risk cytogenetics or high-risk factors for myeloma that you've heard of already, the international staging system? And we put all of this together to come up with the best treatment regimen for the patient. In the future, we will add to this something called genomics and trying to really individualize therapy, so that when we look at your genetics or genomics, we can say, yes, you would respond better to drug X, Y, and Z, and you would respond to something completely different, and we should not be treating you just because you have multiple myeloma. So the first question for you is, What is the goal of therapy in a patient with newly diagnosed symptomatic multiple myeloma? Is it complete response or remission? And I'll talk about that. Is it partial response, so giving it a 50% response? Is it restoring or improving quality of life, or are A and C correct?
Who'd have believed you'd come along? Hand, touching hands, reaching out.
Is this because I'm from Boston that you put this? All right. So the answer is A and C, absolutely, which is making sure that we get the best response possible, but also making sure that your quality of life, that your care is not just for the disease, but for your whole person and for your whole physical activity too. So let's go through what are the goals of therapy that we think of as physicians and trying to make sure that we put it together with you. First thing is, yes, I do want to get your best response possible. It doesn't have to be all the time getting to MRD negative disease, and I'll come back to what is MRD, minimal residual disease, but trying to achieve the best response possible, and what we call here VGPR, which is very good partial remission. That's 90% reduction of your protein in your blood. That's trying to get to the best possible of getting rid of all those plasma cells in your bone marrow and getting rid of the protein that they secrete in the blood, so that's how we measure it in the blood. So that's that term VGPR. Then the second thing is how fast we get to the response. Now again, we don't have to get it within 1 or 2 cycles, but we're trying to get you to the best response as soon as possible. And again, putting drugs together gets us to that best response. So 3 drugs, and in the future 4 drug combinations, usually gets us to attack the cancer cells in different ways so that they kill them much faster and you get to this best response faster. And then at the end of the day, you don't want to have all the side effects. And I'll go through the side effects of those drugs. But the hope is that we really give you therapy that is not toxic, that does not change your quality of life, that you can work full time if you want to, and you can travel, and you can do all the things you want to do. Now, I can tell you we have changed a lot in multiple myeloma. When I was training at Mayo Clinic and I was a fellow, we used to do something called VAD chemotherapy. None of you know this, and none of you have been treated with VAD chemotherapy, vincristine, adriamycin, and dex. We used to put a line just like the leukemia patients, get you in the hospital, admit you, and you lose your hair, nausea, vomiting, very toxic, very bad therapy for us. And this was the standard of care for so many years. And then we suddenly changed into novel or targeted therapies when thalidomide came on board, when one of those new drugs, a pill drug, came on board. And now what we treat you with mostly are pill drugs. And you'll hear about it, Revlimid or lenalidomide, even the new proteasome inhibitors. We have something called ixazomib or Ninlaro. It's another pill, and steroids are pills. So many of you will probably be receiving 3 pill drugs, no loss of hair, no hospitalization, hopefully, and you can continue on with your life. And you don't have to tell everyone that you have multiple myeloma. So that stigma of myeloma therapy has changed, and hopefully we will even change it more as we get better therapy in the future. So, and the most important thing, of course, is I want to live longer. I do want to see my grandkids. As you saw Kathy's, beautiful video, that's really what we want. We want to make sure that hopefully we do not change the survival of patients, that you have a normal life and you can live and get older and have all the other problems in life that we all have. Now, the next slide, and this is very important for me because that's what I do for a living now, is should we treat smoldering myeloma? And I'll tell you, the standard of care to date, and hopefully that will change very soon, is yes, we observe until end organ damage. So what does that mean? Smoldering myeloma means that you have enough cancer cells in your bone marrow, more than 10%, that likely you will develop multiple myeloma, and the chances of progression usually are 10% per year. So if you're age 40, at age 45, you will have a 50% chance of having myeloma. And when I say having myeloma, it's not really having something new. You already have the myeloma. It's having end organ damage, having damage of your kidneys or anemia or fractures of your bones or high calcium and other things. And I usually say to all my patients, well, if you had breast cancer or colon cancer and you had a small lesion, I will never sit down here with you and tell you, you know what, it's okay, leave that lesion in there because you're asymptomatic. Wait until you have metastasis everywhere and fractures in your bones and damage of your kidneys, and then I'll treat you, because right now you don't feel it. Yet we do that in every single day with myeloma. So breast cancer, lung cancer, prostate cancer, everything else, we treat it early because we know that metastasis is bad for you. Myeloma, we have completely had a very different approach, and it could have been because in the old days, we had bad drugs, we had melphalan, we had really poor drugs that are cytotoxic. So we said, fine, let's wait until patients have symptomatic disease, have end organ failure. Remember, failure, like we're making your kidneys fail and your bones failing before we treat you. And I think that whole idea of treating when you have symptoms is probably wrong, but we need to think about it in a good way. So what we're doing right now is we're thinking, how can we change that? How can we change the standard of care? Can we develop drugs that really prevent end organ failure, but also potentially cure you at an early disease? When you have less cancer cells, you have a chance of potentially being cured at an earlier step. Now, not everyone should be treated, and I can tell you that. Many patients will never develop myeloma in their lifetime because their chances of progression are very, very small. But we are currently actively working on trying to understand who will progress and who will not in their lifetime. And we actually have a nice grant from MMRF really working on understanding that, but also developing clinical trials for patients so that if you do have high risk, then you go on a clinical trial with drugs that are not experimental, with drugs that are well known in myeloma, but just bringing them earlier. So again, this is one area where the standard of care is probably going to change in the next few years. And you can see there are lots of ideas and lots of clinical trials ongoing now so that we change the practice and we no longer wait until you have end organ damage and then we treat you. Then the next step is, well, if you do have active myeloma, you have fractures in your bones, anemia, lesions, and not just fractures, or kidney failure, or high calcium, or other factors that we call the new criteria, which is a 60% plasma cells involvement, or having a light chain ratio that's very high, so it will affect your kidneys and it will damage it, or having multiple lesions on an MRI or a PET-CT scan. We say that you have active multiple myeloma. At that point, we start thinking, well, should we do a stem cell transplant or not? And that also will change in the future. But for now, we start thinking, are you going to be fit for a stem cell transplant or not fit for a transplant? And in the older days, we used to say that that's by age 65 or 70, different areas will say transplant or no transplant. I can tell you that we are not against age, and we should not be, ageism is a big problem, so we should not really be using age as a factor. We should think of it more as a fitness and as well as a decision from you whether you want to be transplanted or not. So whether you're 70 or 75, if you're good and fit and you can get into a stem cell transplant, we should consider it at least. Two is we start with induction therapy, meaning we are starting with the beginning of therapy for a few cycles, 3 to 4 cycles. And what we want to do is we want to give you our best drugs up front. We're not going to keep the good drugs later on. Forget that. We want to give you our best drugs early on and give them as a combination of therapy. So 3 drugs together is the standard of care now. In the future, you'll probably hear about 4 drug regimens. So what we use is best drugs are proteasome inhibitors, and I'll talk about that in a second, immunomodulators, and I'll tell you what those are, and steroids. And we put different combinations of those 3 drugs together. Now we have a few other options like Cytoxin and so on, but mainly we're talking about 3 drugs from different classes. So when we put them together, each of them will attack your cancer cells in a different way, and by doing that, you get that best response possible. Now, after that, once you get into a good response, usually after a few cycles, 3 to 4 cycles, we think of the transplant. And this is when we do something called stem cell collection. So we take you through treatment. We take your stem cells out from the peripheral blood. So this is not, harvesting your bone marrow and pulling all the cells from the bone marrow. We actually give you something that makes the stem cells go out in your blood, and we put you on a machine just like a dialysis machine and pull all those stem cells out and store them for you. And they're stored there for a very long time, over 10 years, 20 years, so they're good for you to use them whenever you want. If you decide you will go for the transplant, and I'm saying if you decide because that's a big discussion, that's hours and hours of discussion, should I go for a transplant or not? What are the good things, what are the bad things about it? But if you go for a transplant, then what we usually do is you go in the hospital, although other places do it as an outpatient, and we give you this big high dose chemotherapy, very high dose. And think of it as having weed with your grass and you don't know how to get rid of the weed, which is the bad plasma cells. We come in and kill everything in front of us, which is this big high dose melphalan. So it kills your good cells and your bad cells. And by doing that, you're trying to get rid of the weed. And then we come in and put your seeds the next day, which is those stem cells that we collected from you a few weeks before. And those seeds will hopefully grow into the grass, and hopefully the weed will not come back. That's not a cure. That's trying to get you to the deepest remission we can with this treatment. That's because we know that high-dose melphalan, that drug that we give you, although it kills your good stem cells, is probably one of the most active drugs for myeloma. Now, in the future, you think, again, this could be very archaic in the future. We would think, why are we doing that? Why are we killing all your good stem cells? Why are we making you have the nausea and vomiting and loss of hair and being in the hospital for 2 weeks and have a 1% chance of mortality? So hopefully in the future, we will get rid of all of this big chemotherapy. But so far, right now, it's one of the drugs or one of the options that we have that improves survival for our patients with myeloma. If you are not a transplant candidate, then we would probably give you the same drugs we gave you up front, unless you cannot tolerate them, and we can give you lower drugs or 2-drug regimens only. In general, again, we're trying our best to still get you into the best response possible, even if you're 85 or 90 years old. And as long as you can tolerate the drugs, as long as you're doing well and have a good fitness, then we would like to get you to the best response possible. Now, this will be very complicated, but it gives you sort of a sense of all the options we have, the alphabet soup that we have. The good news is we have a lot of options for myeloma. 10 years ago, we did not have those at all. We had 2 drugs, as you saw. We had 3 drugs at the most. Now we have so many drugs, FDA approved, and hopefully so many more coming along that we will be able to really choose from them so that one patient does not get the same treatment like the other. Someone who has bad cytogenetics should not be receiving in the future the same thing like someone else who has a lower risk of cytogenetics. But in general, we give you 3 or 4 drugs called the induction therapy. Then we give you the transplant or no transplant, and then we take you through something called maintenance therapy. So yes, you will be receiving therapy for as long as we can. And the reason for that, the reason why we don't stop therapy, is we found in clinical trials that if we give you maintenance therapy, a little bit of Revlimid or a little bit of any treatment, it prevents those myeloma cells from coming back and causing relapse. While if we don't give you anything and we just watch you, then most of those myeloma cells could come back a little bit faster. Again, there are so many new drugs, as you can see here, being developed in the maintenance therapy. So we're changing the regimens as we speak, but for now, most of us are using one pill or other drugs like Revlimid and so on. So now, again, let's talk about what do I expect when I start therapy and what are the side effects? Because we think of remission and getting you into the best response and what are the clinical trials. You're thinking, is this going to make me sick? Am I going to be able to work? Am I going to be able to go and visit family or travel and do other things? As well as, of course, will this help me live longer? Will this help me keep my lifestyle? So the first thing that we think of when you're ready for getting myeloma therapy is you want to know what the options are. You know what are the drug combinations that you're going to get and what are the side effects of each of those drug combinations. And it does take a long time understanding this. I can tell you, if your doctor did not spend a few hours really explaining everything, then you have the support of MMRF. You have the support of many of us really going through each of those drugs and the side effects and how to take them. We still see many of our patients either taking the drug at the wrong time or missing doses or not coming because they're still confused of all the regimens. These are very confusing regimens. We don't give you just one drug. We're giving you 3 of them, and one of them is on and off, one of them is every other day, and so on. So there are lots of options to think about, and you have to know and understand your regimen. So the first thing is, and I'll take you through 3 classes of drugs that we think of. So remember that the standard of care, let's say that I'll tell you it's called RVD, Revlimid, Velcade, and Dex, or lenalidomide, which is the real name for it. Velcade is bortezomib, and dexamethasone. Where did that come from? It's basically coming from 3 classes of agents. The first class is called immunomodulators, or IMiDs, and one of them is this Revlimid drug right now as a standard, but it came originally from another drug called thalidomide. How many of you guys know what thalidomide is? Yes, many of you know, yeah. So the story is very interesting. Thalidomide was used as an anti-emetic, as a sleeping pill for pregnant women. For many of them were taking it. And in fact, in Germany, this was a big thing because many of them were taking it, and this is when their babies were born with malformations, missing arms and missing legs. So it was a huge problem, and it came off the market, completely banned. Yet here in the US, we started using it for some other things, leprosy, for potentially some HIV patients. And the story is very interesting because one patient and his wife, the wife was a lawyer, were seeing Dr. Bart Barloghi in Arkansas, but now he's in New York City. And the patient had all the treatment, was going to die, and the wife was saying, well, what else can we use? Can you call someone? So she called Judah Falkman in Harvard, and he told her, well, I'm working on this blood vessel drug called thalidomide because it kills the blood vessels. It's an anti-angiogenic, so it kills the blood vessels, and those are in the bone marrow. And we know that probably myeloma, in those days, all the cancers were starting to think of it as a cancer that is fed by the blood vessels. So we know that myeloma has a lot of those blood vessels in the bone marrow. So maybe thalidomide will work in myeloma. And this is, again, the power of patients changing the way we think of treatment. And this is very important because you guys have the power to change the treatment. So the patient convinced Dr. Barloghi, and then they finally got approval for 3 patients. The first patient did not respond, her husband. However, the other 2 patients had an amazing response. And based on that, so it's not based on actual work from us at all, not based on research, it was purely based on a patient empowering us to really change the treatment that we have. Based on that, a small phase 2 trial was done. So again, clinical trials are very important, and it showed an amazing response with thalidomide in patients with multiple myeloma. And that's the new story of the new era of myeloma treatment, from the old drugs of chemotherapy and losing your hair into let's start thinking of novel drugs that truly attack the cancer cells. Now, after all of those years, now we know how thalidomide works, and it actually doesn't just work on angiogenesis, it works specifically on cereblon and Icaros and all of those fancy things, but we know very well how it works now. Now, the next generation of thalidomide became lenalidomide or Revlimid, and we have a 3rd generation called pomalidomide, and hopefully very soon we will have even other next generations. But this is one class, so you will probably get one of those drugs, and this is those Revlimid or pomalidomide or thalidomide. Now, what is the side effect of Revlimid? Because that's important for you. It can cause rashes, it can cause diarrhea, it can drop your blood count, so these are very important, but it can also cause blood clots in about 15 to 20% of the patients. And I think that's very important to remember because you do not want to develop a blood clot, so you have to be careful. What am I at risk for? And should I be on an aspirin or should I be on a true anticoagulant like heparin and other new agents that we have now? So we have pill drugs that are anticoagulants for our patients. So again, remembering the risk, remembering that if you get suddenly swelling in one leg or shortness of breath, you have to call your doctor. This is very serious, that it can happen in some patients. The next thing, again, as I said, is the aspirin or low molecular weight heparin. And again, we have so many other drugs now that we use to prevent clots in our patients. So the other class of agents is Velcade. And again, there are several generations now of this drug, but Velcade is a proteasome inhibitor. So we have others like carfilzomib and now ixazomib or Ninlaro. What is a proteasome inhibitor? And I'll tell you in a few minutes because we're running out of time, is in your cells, in your cancer cells, you're secreting a lot of protein. So those myeloma cells love to secrete the protein. That's why you get that M spike. So those cancer cells, because they have this big amount of protein, they need a big garbage disposal to get rid of the protein. And the garbage disposal is called the proteasome. And if we come in and block the proteasome, you get all this waste protein stuck in your cancer cell, and it doesn't know what to do with it, so it dies. It does something called apoptosis. So it will die on its own because it has all the toxic protein stuck inside the cell. While a normal cell, if you block the proteasome, it's not a problem. They're not making enough protein, so they're fine. So the difference between a cancer cell and a normal cell, by blocking the proteasome or the garbage disposal, makes the cancer cell die and a normal cell does not die. And by doing that, again, we change completely the way we treat myeloma because now we have all those great agents of proteasome inhibitors that kill myeloma cells. What's the problem with Velcade? The biggest problem is peripheral neuropathy, is that you can have numbness and tingling in your hands and feet. And this is very important to remember, that if you start having that, you have to really go to your doctor and tell him, because we can cut down the dose or even stop it, or change to newer drugs that do not cause the neuropathy. So Ninlaro is a little bit better. Carfilzomib does not cause the neuropathy, although it has other side effects. So again, managing the neuropathy, making sure that you tell us about it so that we treat it early, because the last thing we want is you have really bad neuropathy to the point that that affects your life, and now you're stuck with the neuropathy for the rest of your life. So here is the response criteria. You do not have to memorize this, but just for you to know that we go through a lot of things to start thinking, are you in a complete remission, meaning everything is gone, the M spike is gone, the plasma cells, the bad guys are gone from your bone marrow, or are you in less than that? So VGPR is 90% reduction, PR is 50% reduction. Does that really matter? It matters that we try to get you to the depth of response as much as we can, but we do not have to push you to the extreme if there is toxicity or if there is other problems. In fact, we do have some patients who have a small M protein that lasts for years and years. We call this MGUS-like. So it doesn't take you into a complete remission, but it takes you into a stage that is just like MGUS for years and years. So yes, we do want to get you to a deep response, but don't try to just say, oh, I do have to get to MRD negative, or I do have to get to CR, because sometimes it's okay to stay in a VGPR for a long time. And here's the MRD. What is minimal residual disease? Now, this is not standard of care yet in all the places, but in many academic centers, we are using it. And what it means that even when we get you to a complete remission, even when we say, well, I don't see any more plasma cells in your bone marrow and your M spike is gone, there are still leftover cancer cells that we do not see in the pathology by the eye. So this is why we're doing now better studies by sequencing or by flow cytometry to really get to the next depth, which is the minimal residual disease. And we know now that if you get into MRD negative disease, that will get you a better response and a longer remission for many more years compared to just complete remission. Hopefully that will change in the future as we get more and more of those drugs. Finally, maintenance therapy. So you got induction therapy, you went for transplant or no. How am I going to keep that good remission for longer? So this is where we give you a maintenance therapy. In general, most of us now are using something called Revlimid, which is the same drug that I told you, but at a lower dose, at 15 milligrams. And that's because we did clinical trials comparing nothing versus Revlimid, and we found that indeed Revlimid gives you a longer progression-free survival. Now, if you cannot get Revlimid, or if you have higher risk features, we try to add drugs to it. So we sometimes add Velcade, the same drug that we give, but under the skin every 2 weeks. Or now we're testing antibodies, or we're testing Ninlaro, the pill drug that's like Velcade, as maintenance therapy for our patients. Now, one thing that I would really encourage you to think about is clinical trials. The first thing you're doing when you go to your doctor is you're thinking standard of care or clinical trials. And many of you will start thinking, well, clinical trials may not be the best option because I don't want all the burden of going in and out. Yet I can tell you that right now, the best drugs that are coming along are probably in the clinical trials because we're bringing the new innovation, we're bringing all the new drugs that are not FDA approved yet in clinical trials. So I would strongly encourage you to think of clinical trials. These are not experimental as a phase 1 where we're trying them for the first time. There are some of those, but most of those are drugs that we know they're safe, we know their toxicity, and we're putting them in the best combination possible so that we can get you the best drugs as soon as possible. So again, really encouraging you to consider clinical trials because they may actually be one of the best options for you in your treatment. So basically, you have to have this check box of, okay, did I think of all the options? Did I think of clinical trials? Have I seen a specialist? What are my treatment options? What's best for me as a person? But also moving on to understanding risks and benefits. And I would say really talk with your family, have them involved too, because it's really an important decision and it's a big decision that you're taking in your life. So I'll stop here and basically take you through, we talked about smoldering myeloma, and yes, the standard of care is watch and wait, although hopefully that will change soon, and really think of it, and please email me or call me if you have smoldering myeloma, happy to talk to you anytime, or if you have MGUS or you have family members with that. If you have end organ damage, you have active symptomatic myeloma, the treatment right now, trying to get you to the best remission as much as we can, complete remission or better if we can. 3-drug regimens, although we'll add more and more drugs, and you'll hear about all the new drugs in the relapse setting that we're bringing earlier, trying to take you to transplant if you are eligible, and then maintenance therapy with 1 or 2 drugs so that we can prevent progression and prevent those myeloma cells from coming back. As we talk in the future, in the next sessions, we will talk about precision medicine and how we're looking at you as individuals and not everyone getting the same regimens like we're doing right now. So instead of 3 drugs and 4 drugs to everyone, we're trying to really understand what are the genomics, what is so special in that cancer cell, and how can we attack it in a different way that's better, that can kill it much faster. So with that, I'll stop and answer any questions. Thank you.
Great job, thank you. So since you have a particular interest in smoldering, there were some questions about the use of vitamins and supplements in smoldering, in particular astaxanthin. What are your thoughts?
Yeah, so again, I think it's perfectly fine to use supplements. A lot of people take curcumin, a lot of people take potentially metformin if they have early diabetes. These are drugs that potentially may benefit or may be helpful in preventing progression, but we don't have very strong data to say yes for sure. I would say being healthy is perfectly fine, and having supplements as long as you tell us which ones they are. If you are going to go on a clinical trial, we really need to know what are those, because sometimes they do interact with the medications that we give you.
You mentioned the great patient advocacy story about thalidomide. There's a similar story behind the dexamethasone use, high dose versus weekly, and the question is really, why is dex used, and does it really help myeloma?
Yeah, so dexamethasone actually was developed at Mayo Clinic. So they have those big areas where they say how they really got to understand how dexamethasone is used. And originally when we started using steroids, it was part of the VAD chemotherapy, and then many people said, well, the dex is the most active part. Then in MD Anderson, they had Dr. Alexanian, who actually started saying, well, why don't we just use dexamethasone 4 days on, 4 days off? So in the older days, which was just 7, 8 years ago, that's the older days, we used to use the Alexanian method, which is 4 days on, 4 days off of 40 milligrams of dexamethasone, very high dose. And this became the standard of care for us for many years. So thalidomide versus dex, it was Thal-dex versus that high dose dex. And then Vince Raj Kumar at Mayo started because of a patient who said, you know what, I hate the dex. Have any of you guys have taken the 4 days on, 4 days off of the dexamethasone? Some of you, yes. There you go. So if anyone tells me I love the 4 days on, 4 days off of dex, then I'll be very surprised. It's a killer because it makes you so agitated. The side effects are crazy, and then you can't sleep well. You fight with your husband or your wife, which could be problematic. And then the 4 days off, then it's another, you're fatigued, you're tired, and it's like on and off all the time. And the patient actually tried to convince the physicians, because all of us were like, oh, it's fine, it's just steroids, you'll be fine. So the answer is no. Again, patient empowerment is very important. And try and really convince us to do a clinical trial of comparing the once a week dexamethasone versus the 4 days on, 4 days off. And guess what? Because we never thought that this would be true. It was almost the same response rate, slightly different in some of the subgroups, the younger patients, but almost the same response rate, and less toxicity, less problems, true problems like blood clots, like AFib, like infections, like mortality, and so on. And because of that, because of one patient empowering us again, we changed the regimen, and now most of us are being treated by the once-a-week dexamethasone.
That's a great story. I think you alluded nicely to the use of triplet induction therapy or initial therapy, and some of the questions are, what if you don't respond? And I would broaden it to say, what if somebody doesn't tolerate it? So what if that doesn't work for the patient?
Yeah, so again, most patients respond when we say 90% response rate, 100% response rate in many of the trials. However, not everyone will respond. If you do not get the best benefit or there is no response at all, that's very different. We change regimens, so we start thinking of other options. And again, this is where your genomics matters. This is where COMPASS study makes a difference, because you truly understand what's going on with those cancer cells. Why are they not responding to therapy? But if the response is suboptimal, sometimes we add more drugs or we change drugs and so on. And again, this is where talking to your doctor, talking to a specialist in myeloma is very important because we can tailor therapy for that response and try to find the best combination, best regimen for you. It doesn't mean that you will not respond to the next regimen, so it's not doom and gloom. It could be that this combination is just not the right combination to kill those cancer cells, and the next combination, even if one of those drugs is repeated again, so even if we switch to carfilzomib Revdex or carfilzomib Pomdex, we're using the same classes, but we're using a different one from those classes, and sometimes that works very well. So again, don't give up on your treatment. I'm not saying that you have to, shop around 500 physicians, but definitely be more active in your therapy, deciding together what is the best combination for me, and if that doesn't work well, what is the next combination for me.